much you talk in million years. When I kind of switched to WHO, of course, it was a completely different way of looking at systems, especially coming from, the environment, going to public health. There were a lot of similarities, but there were also a lot of complexities. So it was a very interesting shift. I worked at WHO during 12 years, so up until 2011. And then I had to leave WHO because of the restructuration. You have maybe heard about the financial problems of the WHO. So I was one of the persons having to leave, and that's where I became a consultant. That has been the case for 5 years now. I had the chance to travel in more than 40 countries, where I've been working on GIS in public health. I worked really closely with the Ministry of Health in around 15 of these countries. I had the chance to live in 4 countries already. I'm born and from Switzerland originally. I lived in Tunis until the Arab Spring. I was blocked there during some time before I got released. I started to go more east. I lived in the Sultanate of Oman also during 3 years, so in the Arabic Peninsula. And I've been now living in the Philippines for a year. So I have kind of some experience of different continents and different type of settings. I had the chance to be at the origin of a few big projects. These are just some of them. SALB was a project we launched and we managed over 10 years in the UN system, working with national mapping agencies, including Baco-sur-Tanal at the time, for looking at administrative divisions. So we were following all the Kabupaten, Dakota, and other administrative divisions were changing, working with Baco-sur-Tanal for this information to be shared with the UN community. VIRA stands for Vulnerability and Risk Analysis and Mapping. That's a program I manage out of Tunis for doing geographically based risk assessment in countries. And I'll mention that a little bit later in the presentation. Access Mode is something we'll talk about this afternoon, which is another tool for looking at accessibility to healthcare. And more recently, SIM, which stands for Strengthening Information Infrastructure for Emergency Management. So that's my other hat. I'm working in health and also disaster risk reduction, emergency management. That's a project funded by the United Arab Emirates to look at a different approach for data preparedness in countries, working in Morocco and in the Philippines. So I'm really looking on these different aspects, the geographic dimension of public health, and also on disaster risk reduction and emergency management, because these are 2 interesting drivers to look into information system, as it talks to decision makers. And just to finish, so I'm more a content and method-oriented person. I strongly believe that content is the key in the center, as I will mention in my presentation. And the method is really what is driving what needs to happen when you push the buttons. There has to be a good understanding of what you're trying to achieve, and that has to be based on good data. Okay, so that's where I'm coming from. Now, if we look at public health, I'm sure you all have an idea of what it is, and this is the definition you can get from the WHO website. So basically, it refers to all organized measures, whether public or private, to prevent disease, promote health, and prolong life among the population as a whole. Okay, so that's what public health is about. What WHO is mentioning also is that the 3 main functions that it's supposed to cover is, first of all, assessment, so basically risk assessment of the population to identify what are the problems and the priorities. Access to healthcare, right, to make sure that there's an appropriate and cost-effective care being accessible to the whole population in need. And then the third function that the WHO is mentioning is the formulation of public policies, right, to address the problems that have been identified through the first 2 points. So my first question to you is, where do you see geography across, among these three functions. So who has an idea? Where do you see geography in there? None of them, some of them, all of them? Inaccessibility, yeah, okay. Any other view? All of them, okay. Any other opinion? So everybody will agree all of them, or some of them, all of them? Okay, well, let's have a look a little bit more in detail. So when you look at risk assessment, there's definitely a geographic dimension there, because the highest risk is encountered in the places where you have an hazard, you have to be exposed to a particular hazard, right? And that is independent from the hazard you are looking at, be it biological, be it technological, natural, or whatever, right? So you have to have an hazard. Then it's also where the vulnerability is the highest, right, and where the capacity is the lowest. So these areas where you have the combination of the three is where you get the risk. So yes, by definition, you have a strong geographic dimension there, right? And this concerns as much population than the infrastructures, right? You guys are prone to earthquakes, so you're very much aware about this, and the sensitivity for the buildings to still be operational in case of an earthquake, but also the services. The health services need to remain operational. Maybe the building is down, the doctor, the nurses, and the equipment can still be running in a location nearby, right? So all of this is to be taken into account. So there's really a geographic dimension to risk, right? And at the same time, this is also at the origin of modern epidemiology. I'm sure all of you have heard about John Snow and he used a map back in the end of the 19th century to identify which pump was at the origin of a cholera outbreak in London. That's an example I have seen again and again. That's not the only example you find in public health, but basically this is the first one which shows how map and geography can be used to identify the origin of a public health problem. So yes, definitely for risk assessment, there is a strong geographic dimension there. Then when we look at accessibility to healthcare, like the colleague was mentioning before, if you want to look into this, you need to take into account several components. Like Pagugu was mentioning before, what he was just showing is the referral between different level of facilities. But you need to start also from the population. And then the condition of this population and the intervention they need to follow will have a big impact on how much time they have at disposal to reach the facility. So that's an important element that needs to be taken into account. Then you need to know where is the population. Where are they distributed, in which quantity. You have disparities, of course, between the urban and the rural areas, but that's much more kind of granular than just urban rural issues, as you know, especially in a country as big as Indonesia, which is so fragmented because of the different islands that compose its territory. Then, of course, you have all the question of transportation media that the population can be using. From going by feet to taking a bicycle or a beca or having a car, etc. And finally, of course, you have all the parameters which are linked at least not in a usual type of a kind of model, unless you really use geography as a way to integrate all this information. Because all of these different information either have a geographic dimension or are attached to an object which itself is geographically located. Health facility, population, transportation, network, or Like Pagugu was mentioning before, the influence of course, altitude, land cover, etc. So here again, there's definitely a very strong geographic dimension. And you can use geography as a kind of a neutral integrating platform, like I say, for looking at these kind of issues and doing this kind of analysis. I mean, this is something we did in Cambodia and 3 other countries where we combine different types of information, where GIS has not only been used to overlay this information on top of each other, but also apply some models like access mode to kind of have an idea of why is this part of the population basically still delivering at home while they are close enough to a health facility. So you use this as an additional potential explanation for the reason behind a public health issue. And so this allows a more comprehensive and systemic approach to universal health coverage. So you do not only look at the question of insurance coverage, etc., but you can really kind of compare what is the reality in the ground with what should be the image you should see if really people were accessing healthcare in an equitable way. And then when it comes to policy formulation, I mean, I'm just showing you some examples of maps from the global down to the local level. I guess for all of you that have been working or creating maps, like many other media, which is visual, I mean, this is a very powerful tool, powerful media to look at spatial distribution of public health related issues. Why? Because many humans are very much visual in nature, and there are certain things that you can't absorb. I mean, if you have a big Excel file with thousands of kabupaten, it's very difficult for the brain to aggregate this information and look at the potential spatial relationship between these numbers. You need to have them on the map, to have them colored, and different type of information being put on top of each other to start looking at the problem from the different perspectives. And I think this is really the thing that passionates me from the beginning, starting doing GIS and doing mapping, is the convening power of the map. I mean, you can take people from very different backgrounds. And when you have a map, people get to have a common language and be able to say, yes, well, I know what is happening in this area. Oh, but okay, but because this is happening, that can be explaining why now in my part here, this is the result of this original problem, like a pollution problem, for example. So the maps start to become the media for different specialists to share their knowledge and try to look at really a public health problem from a system perspective. Because I don't know if you have also experienced this, but especially at the global level and maybe at the regional and sometimes national level, everything has been silos. You know, you have health, you have education, you have economic and everything. They are really separated topics. But at the end of the day, all of it is the part of the same system. So by fragmenting the system too much, we forget about the connections between these different components. So the map helps to bring all these components together for looking at the problem from a more holistic perspective. So there also, I mean, for supporting information, I mean, this informed decision making and policy formulation, I mean, mapping is important. So in conclusion, indeed, I will argue that geography is very present across all public health. Or at least should be present, but very often it's taken for granted. Geography is taken for granted. We have discovered the whole planet, so it's not so much of an issue anymore, but people are forgetting that it's changing. It's actually changing all the time. The planet is changing. The environment is changing. What you're analyzing today is not going to be the same next year or the year after. I mean, you have seen this year with El Nino also. I mean, I've not seen Yogyakarta that dry a few months back. I mean, it's the first time I was seeing the trees that brown and really people talking about lack of water. Luckily, it has been raining since then, but it was kind of a change. And there are many other changes like this. So now if you look at geographic information systems, so there is really geography is there as the science. And geography, I mean, this is a definition you can find on ESRI's website, which for me it's a little bit more kind of too much IT centered. I mean, we're talking about a computer, software, even if they mention data, they have kind of lose track a little bit on that side. But really what the way you should be looking at this today is as a comprehensive information system that use geography as this neutral integrating platform. So it's the same thing you will be doing in an information system, but you are adding the geographic dimension to it, right? So you use the visualization power and the conveying power of geography to look at your issues from a geographic perspective. And that is to collect, to manage, to analyze, visualize, share the data. That's nothing different from what you will be doing. Now, this is the representation I got from a GIS system when I started working on this system back in the 90s. And I think that that's really the correct way it should be represented. Content, which is really your GIS software. But it's allowing you to interact, to integrate additional content in your database, and then using this content to produce. Outputs is not only maps. I mean, the outputs, as you will see this afternoon, I mean, it can also produce tables. You can also produce graphs. You will do different things. But basically, this is really, you have a database which is geo in nature at the center. And then you have a set of capacities around this that allows you to integrate and do something with this data. And then, of course, what is very much, this is not just that, it's in a different way that you will do that. It's adding something more to this. And very often, and I'll come back to this, people are thinking and seeing GIS as an IT solution, but actually it's not. It's much more a data management application, right, which use some software, of course, but that's more data management than IT. And very often that's part of the problem in countries where it's not working. And you need some hardware. I mean, even if at the time when I was doing my PhD, I was still using one of these big digitizing tables and I had to kind of plot on there. I mean, this is not so much used nowadays anymore. I mean, we have very performing GPS devices when it comes to all the data. You have online satellite images to really digitize the information directly on the screen. But that's not so long time ago that we were still entering everything, you know, point by point on a digitizing table, spending days, if not weeks, to convert that into something that was going into the GIS. But once again, the key really is, if there is one thing to remember, is that content is really the element that makes the difference. Now, what can we do with the GIS? And this is in public health and in any other kind of area. I mean, there are three main areas that you can cover, and they are kind of listed here going up by order of complexity. Thematic mapping is all these colorful maps I was showing to you before, which is basically representing a set of information using different visualization type, dots, cooperatic maps, etc. So to try to pass a message using a map. Spatial analysis will come to this a little bit later and spatial modeling is the more advanced capacities of a GIS, which first of all are used to contextualize or look at the spatial relationship between something, an object, could be a person, could be an infrastructure and its environment. I mean, here it's altitude, for example, but it can also be the spatial relationship to the urban areas, transportation network, health facility network, water pump, etc. So any kind of object to which it could relate in relation to the particular context you are looking into. It helps to look at dimensions such as distances, as you know. How far is a particular thing from this place, like how far is the water source from the house, etc. And also the question of travel time, which is really the thing which is difficult to address if you are not using a GIS. If you want to start measuring travel time or modeling travel time, you basically need to use GIS for that. Now, as I was mentioning, they are listed in increasing level of complexity. So meaning it's, of course, I mean, and I guess it's obvious, much more difficult to do spatial modeling and to create a thematic map using a GIS, but also in terms of the quality of the data you need. I mean, you all know if you do a model, especially if you're trying to be very precise in your model, you need to be very high in the quality of your data. When you do a thematic map, if you have some imperfection in your boundaries, depending on the scale at which you are looking at the map, doesn't make a big difference. But if you apply a model and then your health facility is not on the right side of the river, that might have a huge implication on your final result, right? And then, interestingly, still today, the number of users, I mean, the distribution of the number of users is reversed. You have many more users of GIS for thematic maps than doing, of course, spatial analysis or modeling. Now, the fourth use, of course, is if you want to be able to do that, any of those, you need to have geospatial data. So one of the use of the GIS is to create and manage geospatial data. And if we look at where this goes into, I would say the level of complexity, it's kind of similar as doing spatial analysis if you really want to have good geospatial data. Of course, the quality, that's where the quality should be highest. Because if you kind of start having low quality data from the creation, like if you collect your points with a very low level of precision, when you're going to input that in your model, you will increase the error. And in terms of number of users, I guess we are also kind of quite high in the ranking, because basically you need this data. But still, there's a big gap in terms of the people being trained correctly to generate geospatial data that will be relevant and produce good results when you use the GIS. So we go back to this element being at the center I was mentioning before. Now, to give you some more examples, it would be helpful. Any questions before that? Anything which is not clear? Any reactions? Everything is good? Yeah? Useful? Okay. I hear some yes in the back, so I'm guessing I'm fine. I mean, I already mentioned, show you quite some example in terms of thematic maps. I don't want to show you too many of them. I just want to kind of maybe show some atypical examples where not necessarily we think about this as a use of GIS. I mean, the map can be anything. I mean, you cannot not necessarily map a part of Jakarta, but it can also be the map of a body like you have here. And so you have a map as an entry for a system that looks at a particular case management system. So just one type of application. A growing application is in hospital management, where basically the map is your hospital with the beds, with the equipment and everything, and where you use that directly to have an idea of follow-up of what's happening in each of the rooms, which beds are actually being occupied by whom, so it's your entry point for your hospital management system. one thing which is also starting to emerge is what ESRI call a story map. So using maps to tell a story, that's one of the new capacity in their product, which is still at the beginning. It's still taking off, but I mean to explain something to high-level decision makers under the set of a set of 5, 6, 7 maps with text and everything. It's quite an interesting approach. Of course, the whole web mapping has been exploding over the past decades. There are still issues of bandwidth, and I think that's where a lot of the solution providers are making a lot of efforts for their system to be really much more light and easy to be accessed. So when you have a map rendering, it doesn't take you 15 minutes to kind of upload the image. And then, of course, there are different types of representations. I mean, this is what we call a cartogram, where the map is the map of the world, where each country's surface is adjusted proportionally to its population or to the number of cases. This is, for example, a number of deaths from malaria back in 2003. So what it means is that there is basically no death in the Americas from malaria, but proportionally speaking, is a huge problem when it comes to southern Sahara, southern Africa, Africa, and then Southeast Asia. So it's a fake representation of geography, but which allows once more to kind of try to pass the message and in different ways. When it comes to spatial analysis, so the base of spatial analysis is first of all to use geography as a way to select some of the information you have collected. So for example, you have been doing a household survey and you have been collecting the location of each of your households, and now you want to analyze the results from a geographic perspective to see if there is any geographic reason behind some of the elements you have been surveying. So you use geography to basically extract this information, and then you redo your general statistic based on this subgroup, which is geographically based. So let's say you could imagine that you have done a household survey, and then you are extracting all the kabupaten in Georgia, which are located further away than 2 hours of travel time from the nearest primary healthcare center, and then you could compare that to other kabupaten which themselves are close to this same health center and see if there is kind of a correlation there. Now, at the same time, you can use geography and reintegrate, use GIS to integrate other parameters into your survey. For example, you could extract, if you have the location again of your households, you could extract some other variables like the altitude, question of land cover, question of climate, etc., for which you will have the map. Extract this information and put it back in your data set. Same thing with distance. You could have maps of distance to the nearest, city, or you could have even also your travel time distribution and reintegrate that into your data sets. And then you do the analysis. This is a little bit small, but this was a household survey conducted by WHO almost 10 years ago now, where by reintegrating geography, what we were seeing, the upper graph is basically showing that you have as the distance from the nearest city is increasing, the lower graph is basically the spending. So as people are living outside of the city, they have to spend more money, basically. And the first one, I think, cannot see very much on my screen neither. Now, let me just take that out for 2 seconds. Okay. Come on. So the upper one is, distribution of the percentage of educated adults compared to the travel time to the nearest city. So basically what it shows is that education is going down as you are going away from the major cities by having integrated this travel time into the equation. And then this one is percentage of households with catastrophic spending by travel time to the nearest city. So as you are going away from the city, there is more catastrophic spending in the household. So that was done by integrating an additional geographic component into the survey. So now passing to spatial modeling, I mean, we've been talking about physical accessibility. We'll talk about that later this afternoon. Basically, what spatial modeling is to apply a model. It can be a simple regression on spatially distributed parameters. So you could be combining different parameters together, trying to predict something in relation to public health, or you could have something which is more elaborated, like physical accessibility, where the model behind is a little bit more complex to look at travel time and things like this. It could be also using, and this was a project when I was working at WHO, we use nighttime light to predict income per capita at the subnational level. And in many countries, there's a very linear correlation. And then we were using different parameters that we were re-injecting in there to predict the income we got from different surveys. So that's an example of regression you can apply. What you have here is an example of vulnerability mapping. That was vulnerability to typhoons, actually, in parts of the world. And you can also use that to model hazards or conducting this geographically based risk assessment like I was mentioning before. So using different parameters, using a model, you can try to predict in which area you expect to have a flood, you expect to have damage from earthquakes, and then by integrating information from your infrastructure, from your population, you can combine all of this using the map to get a distribution of the potential risk and use that, as we were saying before, as the base for policy formulation or improving your accessibility issues. Another kind of things that I was invited to do, which was quite intriguing at the beginning. I mean, this is what we call knowledge mapping, but it's more connected to social network analysis, and which I think is one of the future of the GIS, is the possibility to also look not only at the vertical presence of things from a geographic perspective, but see how they are connected together. And one of the factors that influence your network of people is definitely geography. I mean, the likelihood for people to know each other, to interact together in a particular context is influenced by geography. But not only that, also influenced by culture, politics, etc. So in there also there is a dimension, a geographic dimension to the problem. Now, coming back to what I was mentioning to you before, and this is just one quote in an article I found recently. The content is the key, again, simply because GIS is another tool, and it's another garbage in, garbage out tool. And I would say it's even more dangerous because you can make things look very nice by just having few points on the map and doing an interpolation and putting nice colors between green and red and present that to your boss, and he's going to be very excited. But if the data you have put inside is not correct, you're very likely to be actually be much more dangerous with your map than if you did not produce your map. Right? I mean, I just mentioned there's even a book that was written. I never read that book yet, but it says how to lie with a map. And then you can do the same thing with a graph, with a table. You can always retell the thing. You can do the same thing. So it's a very powerful, but it can also be a very dangerous thing. And that's why the content, I mean, really knowing what you do from the beginning in terms of the content and being able to inform the decision maker when he looks at the map and says, yes, you have a good confidence when you look at the map because I have all my health facilities. In my model, I took into account the roads, I took into account the land cover, the population distribution is from the last census. Yes, you can go ahead and say, well, yes, you can be confident and take decision out of this map. Or, no, well, yeah, well, this is more, kind of for information purpose only. We only have few points in there. We are missing a lot of information, but it shows that there could be a high potential for helping us solving the problem. So, conclusion is that geography and time, because of what I was saying before, everything are changing, should be normally integrated into the health information system in countries. That should be natural, right? We have to say in public health, strong geographic dimension, content is at the center, so by reflex we will think that the information system dimension. And you think about any piece of information that you are used to see in this kind of system that is not geographic or chronological in nature. Huh? Well, actually, no. Because as soon as you are looking at what is collected through an information system, it's always connected to something that happens in a given place at a given time. And actually, normally, the reflex of most people, if you say something happened, the first two questions are going to be where and when, because you want to relate to this event, right? But interestingly, and that goes across, so that, even if it's important, and that goes across all the countries I've visited, these are among the two most poorly captured dimensions in any health information system I have seen, systematically across the planet. You go in any information system, time is not captured or is not captured properly, and the geographic dimension also is not captured properly. Sometimes you have a name of a kabupaten, but you don't have it necessarily spelled in the same way than in the next system, next door, in the same ministry, or there is no unique coding system. There's many issues and actually doesn't allow you to really look at the geographic and time dimension of your information. So starting from there, this is really something where, ministries of health, at any level, let's say the health sector in countries, if they want to take advantage of geography and therefore GIS as the tool through which you look at geography from an electronic perspective, should ensure for these two dimensions to be captured into the information system. And that should be done across the whole data management cycle, which, this is kind of a representation of one of the outcomes of 12 years working at WHO. That's what I'm using in any, basically, data management, project I'm managing. If you want to be able to really manage your data appropriately, you need to cover all what you have here in blue on the right, which is what I call the data management chain, which goes from defining the needs, defining the vocabulary, the data specifications, the ground reference, etc., documenting what you are doing, documenting the data, then collecting your data, then cleaning your data, etc. So that needs to take place across all of this. And this is a cycle. This is something that you need to repeat. This is a never-ending story, simply because things are changing, because you have new facilities opening, others are closed, the staffing is changing, the population is changing not only in terms of numbers, but in terms of their health and therefore socioeconomic demographic profile. It's really a dynamic system. And in there, GIS, sorry, it's a little bit blurry, but GIS as a software comes quite far down the line. And very often, this is, I mean, in many countries where I have been, the first question is, which GIS software do I need to buy? And I tell them, no, this is not where you start from. This is not the first question you need to ask. The first question is, what are the issues you are trying to address? What problems are you facing in your country, in your region, in your province that you are trying to address? This is the first question. This will then directly influence what content, what skills you need to have, and what you need to do with this data and these skills to then use the appropriate software for being able to answer the question. So that also is part of some of the issues where people think that doing GIS is buying one of the software, learning how to press the buttons, and producing nice maps. Yeah, that's possible. You will be very excited for 1, 2, 3 maps, but after the fourth one, you're going to say, so what? What's next? What do I really do with this? Where is the advantage and the benefit? So to be able to do this, it requires a different kind of approach to information management, to data management. It requires to have what we call an object-oriented approach. And by object, if you look at public health, we are talking about patients. We are talking about health workers, about health facilities, and then all the different hierarchy in your structure, the villages. I mean, here it's not necessarily specific to Indonesia, but the administrative divisions up to the country level. These are all the type of objects which, and there are many more, these are just examples. These objects is actually where you will attach your information or your statistics, right? You will have information about your patient, you will have statistics or information about your health facility, etc., etc. And then you tend in the information system to aggregate this information up to a certain level for decision making, right? And these objects are how you link with the map. What you actually put on the map are the different objects, and you color them according to the information and statistics that you have attached to these objects. So as soon as you start working like this with objects, and then you have what I will call attributes, and you separate the two, then it's become not only much easier to think geographically, but it's also much easier to manage all your data in general. Because the objects are supposed to be in common to everybody. You should have only one list of health facilities, right? Whatever hospital should be the same hospital in every database across all of you, across all of the system, being in the academy, being in the Ministry of Health or in the private sector. When you talk about one hospital, it's the same hospital for everybody, right? And that's what brings to the notion of registries. This is really the key, not only for GIS in public health, but for data management in general in the health sector. And so what I mean by a registry is the authoritative, standardized, complete, up-to-date, and uniquely coded list of all active records for a given object, right? So for health facilities, that's the authoritative list of all your health facilities in the country or in the province or in the region, with a unique code that everybody will be using. For administrative divisions, it's the same thing down to the lowest level of disaggregation you can observe in the country. So that would be down to the kabupaten and the kotas in Indonesia, right? You guys have still not gone further down, huh? Yeah, village. But village is a little bit kind of different. You have a village head, yeah, but you have decision making at the village level from the government, or does it stop at the kabupaten? Or policies and kabupaten? Okay. But then you need your list of villages anyway, right? So you need these registries, and these registries are supposed to be unique and accessible by everybody, and also integrate the geographic dimension in there. If you do this, then it's easy to just plug your GIS on top. Plugging the GIS on top of your information system is just straightforward. But if these registries are not in place, if among the ministry each division is using a different list of health facilities or a different coding scheme, you will always have a poor guy that's going to spend much of his time trying to match the data from the different sources to be able to make the complete picture, really make a map that is making sense, or doing a spatial analysis, or applying a model that will be correct at the end. So these registries are really central. So I already kind of talk about this a little bit, about why is it important to maintain and develop and maintain these registries. Of course, also for transparency and reporting efficiency, but this is what really will improve data compatibility. Ensure that the data collected by one person is going to be compatible with the data collected by another person. Because you're talking about the same kabupaten, the same facility, the same patient, etc. And this is complementary to what we call system interoperability, which is a more an IT concept, right? Which is where the IT systems can talk to each other. That's system interoperability. Here we are talking about the content, being able to connect among different sources to be able to get the full picture. Minimize duplication of reports. I've seen many cases because of a lack of registry, even in budgets, you have reporting being duplicated or sometimes forgotten. It also provides other denominators. During big typhoons in the Philippines like Yolanda, that you heard about back in 2013, we basically didn't know how many health facilities were below the typhoon. So you basically, when you have such a surface which is touched, you don't know where are the health facilities that could have been affected, those that could have been destroyed. So you cannot even send people to the right place to do the assessment and define the needs. It has been impossible to conduct the assessment. And when you don't have the denominator, if you have 10 health facilities or 5 health facilities in a province, and you said 3 are domains, it's, in one case it's 30%, in the other case it's 60%. It's completely different. So you need this registry as a key for that as well. Report analysis, entry point to GIS. Basically, this is what really helps you as the base for planning, for referral, etc., etc. So these registries should really be key pillar of the information system, right? And also for the use of GIS. If you really want to make it easy to use GIS in public health, you need these registries. Now, just don't look too much. This is what we call a conceptual data model. This is basically the kind of exercise you do at the beginning of a project to identify all the objects that you will need and how they connect to each other, right? And so this is the representation of what we do in the case of a project with the Asian Development Bank for malaria elimination. So what we have here is all the geographic objects that we should be taking into account for eliminating malaria in countries. Just quickly, the part in yellow here is all what is linked to the modeling of the hazard. So it's basically the location of the vector in the environment, so the niche of the vector of the mosquitoes. What you have in blue is the health sector part with health services, laboratories, health facilities, health workers, etc. And what you have here on the side is more the non-health part. So you have village, people, administrative division, etc. What it shows here, basically when you look at this, you can see the overlap between the vector areas and where the population is located and where potentially someone can be exposed to the disease, can potentially be infected, and therefore become a patient, enter in contact with the health system. What's just important to remember here is those that are just highlighted in green, which is basically village, administrative division, and health services, are the three objects that receive the highest number of arrows, meaning which are kind of key to the model. So if you already have your registry of villages, if you have your registry of health facilities, and you have your registry of administrative divisions, you can already go a very long way in public health from a geographic perspective, if these registries are integrated and used in all the systems. What comes after are health workers and, of course, people. That's the most difficult one, and that goes to the civil registration system in a country, right? And that's one of the most difficult registry to put in place because of the highest number of records. It's basically one record for each people in your population. So very often what is being done is you are more going to the patient registry. So you are able at least to capture those people that enter in contact with your health system. So these are the key registries, the basic core registries you need to have in general for proper data management, but in particular also for using GIS in public health in countries. Just to go one step further, those that are a little bit familiar with what we call the health inter-exchange, this is what Evin and COBIT and others is promoting in e-health. Basically, the theory is that if you have a certain set of elements in place and you have what we call an interoperability layer, you can plug any type of system on your mobile phone, on your desktop, on a big server, and the whole flow of information will be kind of seamless and the data compatible among sources. What this diagram shows is that before any data reach this interoperability layer, reach all these applications, right? Any of these different databases should comply to the registries. So if each of them make reference to the official registry, it's a health facility level database, it should be based on the health facility registry. It's a patient registry, a patient level database, it should tap into the patient registry, etc. So if it makes reference to the registries, if it's properly documented, so when it's, for example, making reference to prevalence, to incidence, this should be matching the official, sorry, this is the terminology part. The metadata is the documentation about the database, where it is coming from, who has collected it, how it has been collected. Terminology is what I was just referring before. It needs to tap always in the same definition. Everybody should be talking and having the same perception on each of the concepts which are being used across the database. So if we have different databases talking about prevalence, that should be based on the same definition of prevalence. So once you are complying with the registry, complying with your documentation, and complying with the terminology, any system that will tap into this will automatically allow to have access to all the data and combine this data together. That's the beauty of all of this. Same thing with the GIS. If you get to do the same things, you can then start to be able to connect data from different sources and really have a complete and reliable view on your map. Now, just that's a little bit more technical, more for those that have already been using GIS. The way you do the link between the registry and the GIS depends on the type of object you are looking at. So if the object is more like a polygon or a line, like a polygon will be an administrative division, for example, a line could be a road. So your registry will be your complete up-to-date list, okay, of these Kabupaten, Kota, etc., with the unique code. I know you have a unique identifier already in Indonesia. So this is your registry. Your GIS layer per se is not necessarily integrated into your registry, because you cannot integrate this geometry the boundaries themselves directly in your table. These are in a separated file, right, in a GIS file. But the fact that this unique ID that you have in your registry, as long as you have this unique ID also in your GIS layer, and you have this unique ID also in your table that contains your statistics or your information, allows you to make the link. That's all it is. So your registry is the source of this unique code. This unique code goes into your GIS layer. This unique code goes in your statistic, your information table. As long as you do this, it's automatically linked, and you have all of any information you could be collecting appear on the map, and you can use it in your analysis, in your thematic mapping or everything, right? Now, if your object is a point, can be represented by a point, a health facility, for example, a school, a village, etc. In this case, you can collect the coordinate of this point, right? What we call the latitude and the longitude that you get even on Google Earth or with a GPS device, etc. This information, this latitude and longitude, can be integrated directly in your registry in this case, right? So as part of the field in your registry, you will have the latitude and the longitudes. In this case, the registry is used also to create your GIS layer. And the unique ID that you have in your registry, as long as it is also in your table, in your statistics, in your information table, can therefore directly also be joined with your GIS layer. So again, the unique identifier from your registry, its presence in each of the database, directly allows you to connect this information, these statistics, into the GIS, and then do thematic mapping, spatial analysis, and modeling, etc. Now, the last type of objects are not necessarily fixed. Can be patients, health workers, etc. You're not going to have a GPS chip under their skin to be able to track them all the time, right? But they will always be also located, attached to a particular other object. If you take a doctor, for example, the doctor will have a specific unique ID as a doctor, and he's going to be working in a particular hospital, which will also have a unique ID coming from the registry of health facilities. He's going to be potentially living in a village. I mean, he's going to be certainly living in a village, which also could be captured through the village registry. And he is going to be also potentially working or being attached to a particular administrative division. So there is indirectly a way to find out where this person is located through its place of work or its place of residence, right? The only exception there, and that's already happening in many countries, of course, assets such as ambulances or emergency services is something that are tracked live into GIS nowadays in many systems. I don't know if it's done here in Indonesia already, but in many countries, each of the ambulance has a GPS system and is basically sending regularly a feed to the operation center, and the people in the operation center can see exactly where is the ambulance at a given time and use automatic routine to send a message to the hospital, for example, and says, there is an ambulance on the way with that patient inside, is going to reach you in less than 5 minutes. Be ready to receive the patient. That's kind of the only exception where there is really a tracking which is done on mobile objects. But again, here on each of those, there is your link, again, is the registry and especially the unique ID in those registries. Is that clear, the whole concept of registry and the importance of it? Yeah? Any question so far? No? It's okay? One last thing about the registry, which is the importance of the coding system. This is something which I have seen also very often in many countries and which create a lot of problems. This is an example in Uganda. And this is an hospital that is located in a particular province. And what they have decided to do is to integrate the code of the province into the code of the hospital. And this is done very often because we think it's very useful. We know directly by looking at the code that this hospital is located in that particular province. Yeah, you do that here also. Okay. The problem here is as soon as there is a change in the structure, the administrative structure, and that there is a change in the code of the province, because here it has been split, for example, then you are in front of a difficult situation. Either you keep the same code as before, but then your information about the administrative division is not correct anymore, so it's not of any value. Or you change your code to make it match to the new code, but then you have a problem when you want to do trend analysis, because the health facility has not the same code anymore. You don't know, your system has to be able to say, well, what was UGA 993 as now UGA 999. So the thing here is, and this is really a general, and if this isn't something happening here, maybe something we should look into, never include other objects into your coding system. If you are developing a coding system for health facilities, do not include codes coming from other objects that can change through time. Because from the moment they change, you are screwed with your coding system. And that has happened in many cases. These objects, if you think it's useful, we need to know this hospital is in this particular province, etc. This is captured as different fields in your registry. These fields can change. This is what we have developed in the Philippines, for example, where there is an history system in the back, where there is a new structure, a new province, a new region which is created. This information is changed in the database, in the registry, but it has no impact on the code of the health facility. So we still know that this is health facility 001, but now it is in a new province. So that's the first thing. Second thing, which might seem obvious, but in Iran they have up to 32 digits in their coding system because they use this GUI, this Global Universal Identifier. The problem is if you want to develop an SMS-based system, that becomes, of course, tricky if your code is very long. And the last thing, which unfortunately we keep seeing, don't put 0 in front of your coding structure. This is what is done very often when you have more than 10 regions. We tend to have region 1, 2, 3, 4, 5, 6, 7, 9, 10. So for the code to have the same structure, we put a 0. But the problem is that the 0 tends to disappear. In many programs, the 0 disappear. And in the Philippines, we have this problem. And during, again, the Typhoon Yolanda, we had to have 4 different columns of codes to be able to join the data coming from different sources. Because sometimes they store it as a text, so the 0 was there. Sometimes it was stored as a number, the 0 fall. Sometimes they even put some characters in front, etc. So we had 4 different columns to be able to connect this. This is a small thing, but this is just to show that all this thing is what really will make you get a good data management practices and really a good benefit out of using your GIS or any data in public health in general. And that brings to the need for having guidelines and standards and protocols, etc. in place for really everybody to use and follow these kind of practices. So where do you start after all of this? I mean, there is no kind of a toolkit, but basically, based I would say, on this past 17 years of experience, the first thing, which is really key, is to connect technicians with decision makers. Technicians know their job, but it's very difficult for them to really demonstrate to their boss why they should spend so much time on organizing a database. The boss generally wants the map at the end of the day, doesn't really care how it is being done. He thinks that is something where you have just pushed a button. If you really want to address these technical issues, you need to look into GIS, geographically related public health issues that are of interest to the upper management. That's why in some countries it was HIV/AIDS. In other countries it is risk reduction. In others it could be another topic. What's interesting is accessibility, for example, goes across any program. So there will always be this geographical dimension to accessibility. But that allows you and says, okay, well, you want to reduce or increase access to healthcare for the poorest in Yogyakarta, for example. That's what is high on the agenda of the public health specialist. Then, okay, well, there is a geographic dimension to this, which is, well, where are the poor? Where are these poor? Where are these health facilities? How do they connect? So you can slowly decompose this from a public health decision-making level perspective into the technical issues. And that's what brings you to the second step. Identifying what is the geographic dimension behind this public health problem. As we have seen at the beginning, geography is across. There will always be a geographic dimension to any public health problem. I will argue that you can find this geographic dimension, whatever is the problem, being disease surveillance, being risk identification or accessibility, etc. The third one is really to go into these data management practices. And this is to really improve and ensure that you have a good quality content. So we address the garbage in, garbage out, basically there, by having proper data management practices. The fourth one is trying to integrate this as much as possible into the information system. I mean, this is the long-term sustainability perspective here. And that is done by promoting and supporting the registries. I hope I've been able to demonstrate there are keys there. And that might require to work with other sectors. Of course, health is not in charge of the administrative divisions. That will be with the National Mapping Agency here, for example, or the Bureau of Statistics. That means using these registries really across the whole data management process or chain. At the same time, and only after that, you look at choosing the appropriate GIS technology that will match your needs. Of course, it's very tempting to go for open source technology because for you as users is no cost. And in many cases, it's appropriate and it allows you to do what you want to do. In some specific context, you will want and need to go to a much more stable solution, which will be more the private proprietary GIS solutions. That will be the case in an emergency center that needs to be operational 24/7 to respond to an emergency. You don't put an open source in there. In your disease surveillance system as well, you want this to be working, performing, and stable and reliable 24/7. So it really will depend on the context in which you want to apply this technology. But that goes after having a good understanding of your needs and what you're trying to achieve. And then all of this has to be done always remembering that data management is not equal to IT. I mean, this is part of my crusade over the past decade, is to make ministries of health to realize that this is not the job of the IT to manage the content. I'm not talking about where do they place a database on a server. That's still an IT business. That's database management. I'm talking about a unit in charge of ensuring that the content is collected in an appropriate way, in a standardized way, across the whole organization, using registries, maintaining these registries, and then coming up with this terminology, coming up with these protocols, these standards that ensure. Hi, Alvin. Alvin is the executive director of AVI. That all of this content, right, is there of quality, so that at the end, when the technician will have taken this content, created maps, applied the model, conducted an analysis, he's going to be confident that when he's going to pass this map to the decision maker, they're going to take the right decision or define the policy which will be based on this evidence, right? So this is something which is different. But of course, doing all of this is not necessarily straightforward. I mean, it took me 17 years to come to all of this, to go through all these countries and to realize that this was really independent from the income level, from the culture, from the continent and everything. And this is not something you want everybody to take 17 years to learn, right? Especially with the turnover in the government. I don't know what's the turnaround in Indonesia in the Ministry of Health with the minister. Is it 2 or 4 years? What's the length of the term? 2 or 4 years? But anyway, it's short. It's not 17 years. And the person, when it comes on board, definitely already has his agenda and things he wants to be done. So you don't want to run after the train. So you need to be able to, to be much faster on this learning and have this capacity on board before the new minister is coming in. Especially that there is this lack of data management capacity and culture. The training which I have seen most of the time are focusing on the software. Which button do you push to be able to make this color appear in the legend, etc., etc. And it's very seldom that I have seen that being, integrated into good data management practices. Again, the tool is at the end. I mean, first of all, you need to really manage your content in the proper way. Plus, you all know, one-off training session is very nice. It takes you away from your desk for 1 week. But if there is no follow-up, if you don't practice, it's like a language or anything. If you don't practice, you lose it very quickly. And if you don't apply it on concrete examples, it's also very difficult to kind of get that into your bones, into your habits, right? So it's very difficult with this kind of one-off sessions to really improve, sustain the capacity just by lack of follow-up. So there was basically a need. This is not only some lessons from my side, but there's several people, a group of people in the health sector at WHO, Asian Development Bank, etc. They came up with the same kind of conclusions. That we needed to find a new approach to this capacity building. And that's where the whole idea of having a GIS lab, and I will talk about AIN in a second, to have a GIS lab was an interesting way, a new approach to look into for addressing these issues. So let me talk quickly about AIN. So AIN refers to the Asia e-Health Information Network. It's a network created by WHO back in 2012, so it's quite young, but it's very dynamic. There's already more than 700 members. It's free to be a member. And as you can see, it covers ministries of health, ICT planning, education, etc. And the real objective in there is to help countries with their national e-health development. So the whole use of ICT in health across. They are looking into 4 specific areas: helping with leadership and governance for e-health, building capacities, encouraging knowledge exchange and resource sharing across the network, and promoting standards and interoperability of health information system across Asia and the Pacific. And that was a picture taken last October in Bali. If you have good eyes, you might find Pagugu and some other colleagues in the room. It's a very interesting network. I will really encourage you to have a look at the website and to register, and if you have an interest in this area, to be a member. Alvin, who just came online before and might want to say something after, and Dr. Bonchai are really, I think, giving a very interesting dynamic to this network. And for us, from a GIS perspective, as you can imagine, under the capacity building and this whole sharing, there was really an interesting thing to be done. So what is this lab about? The whole idea was, okay, how can we help countries to geo-enable their information system so that geography and time is already in their information system. So when they are ready and they plug the GIS on top, it's already kind of, automatically getting the objects, getting the attributes, and then people are being able to do something with it much more efficiently. Or to help them to really embed technology, I mean this GIS technology, into good data management practices. It's also a place where you could access really the network of expertise. There's a lot of things going on in the region and in the globe, which are unknown. I mean, the work which has been done here in Georgia, I'm sure is not necessarily known from even maybe the rest of Indonesia, but certainly beyond in other countries in the region. Also be able to help countries to find solutions to their geospatial information and services problems. Could be a very technical problem, not being able to apply a certain model, or it can be a question of system interoperability. They have a GIS on one side, the surveillance system on the other side. They cannot manage to get one to be seen in the other. Something which is also very, I mean, close to what we have been trying to do for now a long time, and which I link also to this presentation here today in Gadjah Mada, is the importance of the academic sector. I mean, the schools of public health is the place where potential future Minister of Health are learning, or at least not only the minister, but other high-level people in the ministry. And very seldom is there a real proper curriculum on medical geography. Very often it is taught under IT. It's seen as another IT solution, but it's more than this. And we hope the lab to be a place where we're going to be able to develop some, and maybe in collaboration with you guys, some curriculum that will be more extended. And allow one day, what I dream one day is the Minister of Health, the first day he comes to function, his first question will be, how does my health information system look like? Do I have a clear idea of how many health facilities I have at my disposal? Where are my doctors? Where are my nurses? And okay, these are my 5 top problems in the country, the highest prevalence. Where are these people? You know, that they will be the one coming and asking these questions. Because for the moment, they don't come up with these questions. And the system is not in place to help them with that. Also be able to test tools. I mean, being able to test applications to make sure that they are interoperable with other systems. That's this whole HIE concept I was mentioning before. And also be able to benefit from public-private partnership. I think that's also the role where the UN system, I mean, has not always been able to be really proactive and effective, is to help the government, the health sector, to have access to lower cost licensing, capacities for training, etc. And then learn from others and other things and others. So this is kind of the whole idea behind the lab, is to be able to have this in place. These are what we call the 4 Ps. That's the kind of the 4 principles that are coming from other labs, which are existing more higher IT labs. Training, teaming, tooling, and testing. So that should be a place where you can come, team, have access to a network, where you can get trained, where you can get some insight to your tools, improve your tools, test your data, test your concept, etc. So it's really supposed to be a hub for the whole health sector in the region, or for building this capacity. This is kind of a visual representation of the middle-term vision for the lab. I mean, there are different concepts, and then maybe I'll invite Alvin at the end to talk a little bit about this. But what AIM is working on is building a community of interoperability labs. So that's more of the IT level, and I think that's where Gadjah Mada could be one of these labs. So kind of a center of excellence where any members of the health sector in the country could come and say, well, I want to develop a system, or I want to make sure my system is going to be interoperable with the other systems being developed in the country in relation to the law, the regulation, the standards, and the protocols which have been established. And the lab, the GIS lab, is something that plugs into this as a regional kind of capacity, but could also very much lead to national capacities also. Some countries like Sri Lanka or even here, there could also be a GIS-related lab, which will be looking more on the geospatial aspect of all these issues, and this with the support of external partners from the donor side, from the UN and the private sector as well. We already have ESRI on board. We already have some building blocks in place, thanks to the collaboration with the ESRI. We have what we call an ArcGIS online platform for the lab. So this is kind of the new direction that the ESRI has been taking with their product. It's a very interesting kind of model for distributed system in GIS. So you basically don't need to have GIS software on your laptop. This is on the cloud, in the cloud, on the net. And you basically put your data in there, run things up there, and get your final map being created. All of this online and shared with those you have member of your network. Of course, you need to have an internet connection. Still remains to these kind of things, but that's a kind of a new approach. So we had the chance to have access to this, and we are testing this also as a solution, as a way to bring the different countries to kind of test this technology. What you can already have access to is a social network on GIS in public health on a platform called GeoNet. So this is a community that we are slowly building. This is a place where you're going to be able to ask questions about your respective projects, where you're going to be able to share also your experience and etc. So these are two already elements which are live and being used. What we also, that was part of the reason why we went to ESRI in Redlands last September, is to get a new set of agreement with Esri. And what we got, I mean, EIN being an NGO, it's possible for EIN to have access to this whole package. But what's interesting is that this ArcGIS online plus the desktop licenses, we're going to be able to loan them to the health sector in countries for free for a period of 1 year, for them to test and see if this is the kind of technology that is needed and necessary to learn also about this kind of technology. And so this is really a new thing that was never been accessible to the government in countries before us. Caveats at the bottom. I mean, we are not trying to promote one technology in particular. It so happens that this technology is really at the top end user of what you can find on the market today. And the president of ESRI, Jack Dungerman, is really willing to contribute to public health globally. And that is part of his contribution to this in there. So that's one of the options which we have the chance to have access to. The other thing we have been able to negotiate with them, and that's the first round of negotiation, is specific price on some packages for the government. And I can tell you, I mean, it doesn't look kind of, it seems still to be quite expensive, and I know it's an expensive technology. But to give you an example, in Thailand, this is 6 times cheaper than what the Ministry of Health will pay for the same packages. So it's still not there yet. It's still something to be paid yearly. And that's why also we have donors on board like ADB to look at new ways of financing this. But also there it's slowly kind of going in a direction where really this high-end technology is going to be more accessible to the Ministry of Health. In the academic sector, there are other type of agreements which are even cheaper than this. I mean, as academia, I know you guys have access to this. I mean, the agreement you get with the SRI is even cheaper than that. We had a soft launching during this EIN general meeting in Bali last October with different events and workshops. And here we can recognize Pagugu a little bit better. He was there, and we had 25 different countries represented during that workshop. And now we have a core group, including Myanmar. We have Myanmar, Thailand, Cambodia, Sri Lanka, that really, and certainly you guys are going to come on board also, that kind of form a nucleus of countries that are very much interested into looking into this. So the next step, now that we have these NGO licenses, is to define how we're going to be lending them. What's going to be the criteria for a country to say, well, I would like to take advantage of this license during a year for doing this, and I need this kind of support to do that. We are still discussing if and where, in case there will be a physical entity. Most probably the lab is going to be kind of partly virtual and partly distributed, certainly some training facility in some place, maybe Hong Kong, and then different capacities in different countries to be able to provide the best support possible. We still need to get the necessarily financial support for this to be sustainable over the coming years, but we are really close to getting that. And we need to have some more staff for the lab as the demand is increasing, because basically right now, to respond to the demand, it's based on these different projects, it's just Mark Landry at WHO and myself taking care of all of this. So it's kind of sometimes overwhelming, but we're very excited by the opportunity that this is giving us and also the health community in the region. And there is also a policy brief, which is in the pipe, which should be accessible to you guys, and basically kind of also summarize a little bit of what I was showing to you this morning. In conclusion, I hope I've been able to show you there is a strong geographic dimension to public health, and that across all the different functions. That GIS can be a powerful tool to integrate data from different sources and manage, analyze, visualize this data. That it remains nevertheless a garbage in, garbage out tool, and therefore the content is critical compared to the software. That unfortunately still today, the geographic and time dimensions are poorly integrated in health information systems in all, if not, most, if not all countries. That if there is really a willingness to take advantage of GIS and geography, there should be an investment made in integrating this dimension in the information system, and that hopefully the lab is going to be contributing to helping the health sector in countries to go through this process with a new approach and taking advantage of the network of expertise that exists in the region. I hope I've not been too long, and I will be happy, of course, to answer questions, and I thank you for your attention.
Thank you, Pastor. Give applause to Pastor. For your information, that this seminar also watched by other 19 country members. We have 4 online participants from Philippines and also from Sri Lanka.
Thailand,
and also from. But basically, the IDEA is open for everybody. And as we mentioned before, that we have 700 members. And how many countries?
I don't know. Alvin could be answering this question maybe. Okay. Do you want to take several questions, or do you want to answer one by one? Yeah. Okay.
Or maybe.
Yeah. Maybe let's take a few questions.
Steve, Pak Gugu. Steve, Pak Gugu, Alvin here.
Just for those that are online, so the question is, how can we address the problems in lack of data and also the quality in secondary data? Well, actually, it's not a question which is linked with the level of income in countries. I mean, you will be surprised that even in countries like Qatar, which are the richest in the world, you have exactly the same issues you can find here in this part of the world. I think that the problem goes back to this lack of understanding of data management capacities and practices that have not been embedded. I think what we are doing right now, we are suffering from these past decades of big push on IT that has been sold as the solution to all the problems. But finally, people are slowly realizing that, yeah, there's no limit to what we can solve from an IT perspective, but the content is not there. And the other problem is it's not very attractive to invest in content. You know, people love to have a report, love to have a website, or it's even easy to take a picture in front of, in the nation of computers. It's kind of something concrete. But investing and improving the content of your information system or the quality of the data does not really show on a picture, or it's difficult to sell, right? And so that's kind of the problems we are all facing. And even in most of my project now, I was trying to find a slide I prepared like 15 years ago, which was showing that 60 to 70% of the time on a project is passed on looking for the data and improving the quality of data. And then we pass maybe 10% of the time to read and analyze the result at the end, while it should be the contrary. Unfortunately, 15 years after, we are still in the same problems. It's still, the situation is still the same. And this is also partly why the lab, the concept of lab is not just GIS, it's really data management and GIS, so that you can slowly improve the quality of the data. The data is there. Very often there is data. And especially in Indonesia, you have one advantage compared to many other countries, is that you have what we call a national spatial data infrastructure, which is in the law. So basically, each ministry in the country are supposed to be developing, maintaining, and sharing the geospatial data they generate according to a set of protocols and standards. This is, I think, one of the only country in the whole Asia and Pacific that has such a law, which means you can find the location of the health facilities on the website of the Ministry of Health, and it's of good quality, and it's complete, and it's up to date. In most countries, it's not the case. Now, we always want more data than what it exists. I mean, that's, by definition, it's the base of also science and research, right? I mean, we're going to go and collect and have new data. To be able to get this data and integrate it in there, you need to have, again, this whole kind of discussion and thinking among the health sector in the country to develop these protocols and these standards and these guidelines, so that slowly you kind of build these data gaps. I don't know which data in particular you were thinking about that you are lacking, that could avoid you to use GIS in Indonesia. because I know there's a lot of data available, primary and secondary for the country. Maybe it's more on the statistic side, on the attribute side, there might be data missing, down to the lowest level of disaggregation. Now, in terms of the secondary data, I mean, that will always be a problem, and that's why part of the process I was showing before, the data management chain, is to assess the different data sources compared to what we call a ground reference. And that's where the registries again are key. The registry is what's going to help you to check the completeness of certain objects, right? If you have different, let's say, database health facilities, and you have your registry, you can use your registry to see which one of the database with your latitude and longitude it's going to be the closest to be complete, for example. So there's some work you can be doing to assess the quality of your secondary data to a certain level. A certain part will remain unknown, and you will have to deal with it. But that's where the metadata, the documentation comes in. That's the work of the technician to kind of document and says, well, this is the data I have been able to access. These ones, these layers were primary sources considered as validated, completed, and up to date. This one were secondary data known to be incomplete, and most probably we are underestimating accessibility, for example. That's also where the whole question of these skills I was mentioning before, if you are a GIS technician, is different than if you are using Excel or Word or another software. That's where you really see the difference with someone that will have years of experience, is to be able to question the data and really question also the result you will get out of having applied this data, and document the map in such a way that it really not only gives the information to the decision maker, but also inform this person about the level of confidence he can have on what he sees on the map, basically. I hope that answers your questions. And we can have more discussion if you want in terms of the data.
Based on your experience, which related to the availability of data, you mentioned about the registry, main registry that you need to provide. And you mentioned the registry, how the database can be given to the community.
Yeah. No, and that's kind of the big challenge. I mean, from a public health perspective, of course, the kind of key and natural registries are the health facilities, and that's the one that should be accessible. Now, the whole question of patient and health worker, I mean, it's more confidential. It's not necessarily something you get into the public, but for the health sector should also be available. So the health sector, the Ministry of Health, should be the custodian of these three registries. What comes after in terms of the villages, most of the time it comes to the Statistic Office. That is the one in charge, or it can also be Ministry of Interior sometimes, could have the registry. It's in between the two. The administrative divisions is generally between the National Mapping Agency and the Bureau of Statistics. It also depends on the country. So these are kind of the key first set of agencies, I would say, that should be involved. And that's where the NSDI is helping. But I don't know if, and I guess the Ministry of Health is sitting at the table of the NSDI in Indonesia. But I don't know what's happening exactly. And I remember working with Bako Surtanal and when we were doing the SAL project, and actually, thanks to this interaction, they started to put their list on their website, which was not accessible before, with the changes and etc. And I like to think they are still accessible, and you can download these registries, I guess, onto the Capital.
So anyway, actually, I would like to say something.
Let's try. We can try.
experience and probably we ask you about so in the comments. But some people here actually already work with something of GIS. I think as audience like IFP and also projects. They are working in hard office, teaching hard office, and I think in terms of the capacity, there are which difference between the national level and the local level in terms of many, such as the financial capacity, the competency, etc. And what they did so far is actually they use the GIS technology also to introduce the issue in order to develop the process of the registry to how to get to improve the quality of the data management and also to change the mindset that the data management is it's not ideal to just mentioned because actually also you're right that for I think the last many years that we focus in developing the IT infrastructure, which I think now is quite okay, but still lack of the content and they use the GIS. Although they realize that for the data is not yet good, that the quality of the data is not yet good, but they started to show that they can do something with the GIS. And I think somehow it works with the despite of the lack of the data, that they can show some nice maps, and then they show the policy makers even to the parliament that will be the for the aspect somehow they then I think they realize also that we should do something to improve the issue that you just mentioned. And what do you think? I mean, we don't start from the good capacity with the good data management. We start from with many lessons, but somehow it's so the.
No. In many cases, actually, and that goes back to the importance of linking that to an issue. I mean, if you try to look into this as a purely technical problem, and if I was to come in countries and I say, well, I'm going to improve the technical capacity of your HIS people, or I will look into improving your information system, most of the time people will say, well, I don't need it, it's already working, right? But if you put that into solving a problem, like in Iran, we use emergency management because that was high on the agenda, or the question of accessibility to emergency obstetric care in some countries, and says, okay, well, this is the issues you want to look at. And says, okay, well, if you want to look at this issue, you need to look at this, and this. And then you go into your database and go in your registry and says, okay, well, you want to be looking into this, we should have a complete up-to-date list of our facilities with the location, but it's not existing. Okay, I didn't know about this. But because you link that to a problem, then it's easier to go back to the upper management. So indeed, very often, it's by doing the thing that you can demonstrate the importance of improving these data management capacities or the need for the data to be improved. People did not realize it's not there, it's not complete. And indeed, that's a nice way to kind of close the loop and making the decision makers realize about the need of what needs to happen at the technical level. So definitely that's great, but that requires a skills of being able to have the technician talking to the decision maker. And if you have some of these people inside the administration, these are the people you want to really help leveraging. Because that's the most difficult part, is to make really the upper level, upper management level, realize they need to invest in certain things which is of benefit to them. The language you have to use to make them realize is not easy. And that's most of the job I'm doing in countries is that right now, is to bridge the gap between the technicians and the decision makers. So definitely, no, it helps. It's a kind of a win-win situation if you want. That's what needs to happen. Yeah.
Yeah, because we are running out of time, but possibility is still small one. And for you that would like to have a discussion after this, and we can have a basic sheet, or maybe during the lunch, or we can have a discussion. Now, before we close the sentence, Arif would like to take a picture of us and which you set up and now we'll do
Maybe if he talks to he left? Okay. So where shall we go? You want to for the picture? Is supposed to go in front, or you just put the picture like this? Will you stay there?